All right, this lesson is a follow up of the hemodynamics lesson. If you haven't watched that yet, we highly recommend you watch that before you watch this one. In this lesson, we're going to dive a little bit deeper into the world of preload and afterload, as well as touch on contractility a bit. So, if you remember, cardiac output is equal to stroke volume times heart rate. And there's three factors that affect stroke volume. Those three factors are afterload, preload, and contractility. So let's zoom into each of these three factors that affect stroke volume because it plays such an important role in cardiac output. And then we'll try to put it all back together at the end. So, first, let's talk about preload. Now, there's a lot of ways that people use to understand preload, but the best way to think about it is stretch. Okay? Think of preload as stretch. It's the amount the heart stretches because of how much it is filled. So it's the blood returning to the heart that impacts preload. Blood returning to heart is going to have a direct impact on preload. It's going to impact how much stretch occurs. Now, during diastole, the heart is filling up with blood. So one of the ways we measure preload is with something called end diastolic volume. End diastolic volume. Now, in clinical practice, though, it's a little bit harder to measure this because it requires an echocardiogram to get the measurement. So instead, what we do is we use a central line, insert it into the superior vena cava, directly into the right atrium. Remember, the right atrium is where blood returns from the body. This pressure in here is called central venous pressure, or CVP. Okay, CVP. And the normal CVP for a healthy individual is 2 to 6 millimeters of mercury. All right. Now, because preload is defined as a stretch on this muscle, it's not exactly a volume or a pressure, but those measurements give us a good idea of how much the heart is actually stretching. I want you to think about like a balloon. Okay, let's draw a little balloon here. All right. The preload is how much you blow it up. How much air you are putting into the balloon. How much is it stretching? That's the preload. Now, so what kinds of things can cause a change in preload? So we'll say increased preload and a decreased preload. Now, anything that decreases the return of blood to the heart, so things like hemorrhage, dehydration, or even massive peripheral vasodilation. I want you to remember that. Massive peripheral vasodilation. Now, if all the blood is pooling in the body, it's not making it back to the heart, right? So, how can we improve someone's preload when it's too low? Well, we should always try to treat the cause. Usually that means giving fluids or blood products. And that's how we can fix a decreased preload. But what if our preload is too high? Okay. Maybe the patient has a volume overload because they have heart failure. Okay. Maybe their stretch is too high, right? Or maybe they have something like renal failure. Okay. How would we fix that? How would we fix that? In this case, we would do something like we could give diuretics or we could give ACE inhibitors. Now, we could even give vasodilators to relieve the filling pressure on the heart. To better understand preload and the impact of preload, we have to understand something called Frank Starling's law. Now, what this law says is that the more the heart muscle stretches, the stronger it will contract, and therefore the higher the stroke volume. Now, more stretch, more force, higher the stroke volume. What you see is that as preload increases, so does stroke volume. However, this effect is limited. Okay. At a certain point, this curve will begin to level off, meaning that the more preload added at this point won't actually lead to an increased stroke volume. Now, remember your balloon. The more you fill it with air, the more it stretches. The more forcefully it will push that air out if you let go, right? But at a certain point, putting more air into the balloon will no longer cause more stretch and force. But what actually will happen? The balloon is going to pop. Now, the heart itself doesn't pop, fortunately, but it does stop responding to preload at a certain point. So, why is this important? Well, there's a few reasons. First, this curve itself explains why low blood volume or dehydration can make such a big difference in a patient's cardiac output. It's decreasing their preload and therefore their stroke volume. Okay. We also need to understand that at a certain point, just giving fluids won't be enough, and we will have to address something else. Finally, it's important to realize that everyone's Frank Starling curve looks different. Okay. One person might require much more preload to get any change in stroke volume. Okay. They might require much more preload to get any change in stroke volume. While another person might respond really well to just a little bit of preload to get that same stroke volume. All right. And ultimately, we need to see how well the patient responds and address each patient's needs individually. All right, let's talk a little bit about afterload. When the heart contracts during systole, it has to contract strong enough to overcome the pressure on the other side of the aortic and the pulmonic valve. There's a pressure over here. And in order to open those valves, the aortic and the pulmonic valve, the heart has to squeeze enough, strong enough to overcome that valve. Now, it would be kind of like if someone was holding your door shut. You have to push harder to get that door open. The force that the heart has to overcome, that is our afterload. Think about it this way. Afterload is what the heart has to pump against. Afterload is what the heart has to pump against. The higher the afterload, the harder the heart has to work to eject blood. So there's two measurements we use for afterload. One for the right side of the heart and one for the left side of the heart. The one for the right side of the heart is called PVR, or peripheral vascular resistance. Now, the one for the left side of the heart is called SVR, or systemic vascular resistance. SVR is the most common measurement we use for afterload, and normal SVR is 800 to 1400. It's important to note that an increased SVR is closely correlated to an elevated BP, okay, or elevated blood pressure. Now, things that cause an increased afterload, okay, so let's say we have increased afterload and a decreased afterload. So, what kinds of things would cause an increased afterload? Well, some things that would cause an increased afterload would be hypertension, blood clots, blocking the vessels, and vasoconstriction. Decreasing afterload can help to decrease blood pressure and also decrease the workload of the heart. We can do that with vasodilators and antihypertensives. Okay, so vasodilators, antihypertensives, or by getting rid of clots. Now, things that cause afterload to be low would be things like massive peripheral vasodilation or low BP. So first, we want to treat the cause, but we can also give things like vasoconstrictors or vasopressors like norepinephrine, epinephrine, neosynephrine, or vasopressin. This will increase their afterload and therefore their blood pressure. So I've mentioned in preload and in afterload, mentioned massive peripheral vasodilation. Okay. It affects both preload and afterload and can cause major cardiac output issues. We're going to see this in issues like distributive shocks, like septic shock and anaphylactic shock. So be sure to check out those lessons later on in this course. Now, the last thing we want to talk about is contractility. This is the final element of stroke volume. Now, the best way to think of contractility is the force. This is force of the contraction. This is the strength or force of the contraction. Okay, how much force are these ventricles using when they contract? Now, if we find the heart is working too hard and we want to decrease the force of contraction, we could give things like negative inotropes, something like a beta blocker, or we give calcium channel blockers or CCBs. If we find the heart isn't beating strong enough and we want to increase our contractility, we could give things like positive inotropes. This could be like cardiac glycosides. And one you should really know is digoxin or sympathomimetics like epinephrine. Okay. Okay, like epinephrine. All right. Ultimately, though, if my preload and my afterload aren't optimal, the force of contraction or contractility won't be enough to provide sufficient cardiac output. So let's recap a little bit. Cardiac output equals heart rate times stroke volume. Cardiac output equals heart rate times stroke volume. Stroke volume is three factors: preload, afterload, and contractility. Preload is the amount of stretch. The heart is the amount that heart stretches when it's filled during diastole. Afterload is the resistance the heart has to pump against to eject blood during systole. Okay, I really want you to remember the difference between these two and what these two really are. Now, contractility is the strength or force of that contraction, how hard it's squeezing blood out of it. Okay. Now, I really want you to think about this balloon analogy. I really think that the balloon analogy will help you understand this a little bit more. The more you fill it, the stronger you squeeze it, and the tighter you hold the opening will all determine how much air comes out at a time. This is a great way to understand how to improve cardiac output. Does it need to be filled up? Preload. Am I squeezing it hard enough? Or am I holding the opening too tight? Preload, contractility, afterload. All right. Now, we really hope this has helped you understand these hemodynamics and how they affect our cardiac output. As you progress through the cardiac course and learn more about these various disease processes that you're going to see, you'll also see these things factor into their assessment, therapeutic management, and nursing care. Now, guys, I want you to go out and be your best self today. And as always, happy nursing.